Our speaker today is Deborah M. Johansen. She is a dedicated clinician with over 35 years of experience in the behavioral health field, with a demonstrated track record working in court systems with SMI populations, substance use, MAT treatment programs, maximum security prison systems, crisis response, trauma, psychodrama, and she is a Herd Institute certified equine-assisted psychotherapist. She's resided in Arizona since 2006 and now focuses on her private practice, Foundations for Healing, where she works with adults and couples. She provides equine-assisted therapy and offers clinical supervision to interns and recent grads. She's also in process of co-creating a new trauma-centered reentry reintegration program for individuals coming out of incarceration and their families. So without further ado, and a very virtual applause that no one can see, but you can see mine, we're going to welcome Deborah Johansen and hand it off here.
All right. So as we get started, first page, right? That's me. And this became like my brainchild before teletherapy was cool. Years ago, when I was dreaming about having a private practice, I was trying to think about, how that would look. And knowing that some of my professors in graduate school were living in really awesome places like Fiji and other areas, I thought, wow, if my professor can sit on a beach and do teletherapy, teleclasses to us, then why not reach out to this population that I think is largely untouched, the professionals out there who are trying to get on with their lives and dealing with an illness that has a lot of stigma and need for privacy. So as you can see, I have a couple of different descriptions here. This is about a group that I am planning to do, which is kind of the beginning of all of this. And then from my webpage, I'll get started in some of the questions that I've really been throwing around and talking with clients about. So here they are. So the question, are you a professional who's hiding a mental illness? Feeling alone, challenges, wishing somebody else was available to talk to, finding that you don't fit in, concerned about being found out, wanting to keep it confidential, wanting to be able to have a place to go, but not wanting to be around your clients. For individuals who might be a nurse or a doctor or an attorney or a therapist or a psychiatrist, it's really important that they have a safe space that they can go to as well. So I basically am offering that they have a safe place to go that's confidential, and they can do it online. So that'll be the first group that I'm going to be doing, will be online, and then eventually I will offer it in person as well, but it's a closed group. And so that in itself, I'm hoping will provide that security and peace of mind for individuals. So based on my years of information, research, phenomenological, informal study, these are the areas that I think are most important. So the psychoeducation piece, grieving and loss, stigma, managing moods, navigating relationships, and a new normal. So I'm putting a lot of information in here that basically is the definition of bipolar disorder, not because I don't think that you know what it is, but just as a refresher. I'm not going to read all of it, but it makes the slides look better, right? So we know that the DSM describes it as a brain disorder that creates changes in mood, energy, and ability to function. There's 3 different aspects that are typically part of the diagnosis. So we have bipolar 1, bipolar 2, and the cyclothymic disorder. So all of these people are considered to have some sort of extreme or intense emotional states or mood episodes. So they can be manic, hypomanic, or mixed. And there's oftentimes a period of what most would consider to be normal. I also did not see it, but I've been calling the bad side of hypomania, the manic, the dysphoric mania. I've heard other people call it that as well, but that's the piece that I find people to be in the most misery of wanting to change. So there again, the mood swings. We've all seen people, brings the hopelessness, the depression, but also then that elevated sense of self. And here are some of those things that are typically associated through the DSM that we would see: exaggerated sense of self, grandiosity, loss of sleep, not needing the sleep, rapid talking, loud, easily distracted, often scheduling many different activities, not finishing what they've started, increased behavior, recklessness, uncontrolled racing thoughts, changing from idea to idea. So the hypomanic phase is the one that everybody wants to talk about, how, oh, it's so great. Who would want to lose that? And there's a lot of truth to that. Clients talk about that with me all the time. We'll get into that a little bit more. But the depressive side always comes. So for an individual to be truly defined as bipolar, there's got to be some sort of a manic piece along with a depression piece. So here again, we all know the definitions that will tell us somebody is experiencing depression. Loss of interest, worthlessness, sleep problems again on the opposite extreme, changes in appetite, loss of energy, fatigue, concentration issues again, thoughts of death and suicide. So to have bipolar 2 diagnosis, they have to have had at least one major depressive episode and one hypomanic episode. Oftentimes, though, people will have, again, those phases of normalcy in between. Generally, again, people will typically seek out help for the depression piece. And this can fall into one of the reasons why it takes such a long time to get diagnosed. This is particularly common with women. They will go to their primary care doctor because they're feeling depressed. And then they get misdiagnosed because the doctor doesn't see the other side of it, which they don't recognize as an issue. And the cycle just keeps going. On the flip side, men tend to be more likely noticed for the first time and diagnosed when they've gotten involved in the justice system or, a lot of times the justice system or other kinds of areas of unmanageability in their life. Cyclothymia, I haven't seen as much. Obviously milder forms of the mood swings. I think about that. Years ago, I used to have 2 stuffed animals on my desk. It was a tiger and a poo. And I saw that as my hypomanic, manic, depressive, the whole bipolar bundle there with the cyclothymic thing. It's just a reminder to me that we have to be watching for both sides. So again, these are some other descriptions that some are soft signs, some are in the DSM. It's just another way to look at it. So talking about soft signs, this is one of the areas that for me, I really started to delve into more specifically with individuals who were coming to me describing issues and misdiagnoses. So there are some things that now I'm looking for that other people may not necessarily pick up on if they're looking specifically just to the DSM for the diagnosis. This individual, Mr. Aiken, came up with this article, and he refers to the rule of threes, which is a chart that is used to help in diagnosing bipolar. And there you see it. So they look at it more as soft polarity. And these are the things: the 3 failed marriages, 3 failed antidepressants, 3 first-degree relatives, 3 generation family history of affective illness, which of course with affective illness, it can also just be depression. Eminence in 3 fields in the family, 3 simultaneous jobs, proficiency in 3 languages. Wouldn't that be nice? 3 distinct professions, exercise simultaneously, 3 comorbid anxiety diagnoses, triad past histrionic psychopathic or borderline diagnoses, triad of trait, mood, layability, energy, activity, daydreaming, flamboyance, expressed in a triad of bright colors, substance abuse, and I have to move this. 3 impulse control behaviors, simultaneous dating, and 3 individuals. That sounds like a lot of work to me. So they also want to make us be aware that as colorful as all that data is, that it's important to keep in mind that only a minority of bipolar patients endorse these soft signs, between 5 and 30%. These are the kinds of things that clients have reported to me for their soft signs. The hypersexuality, multiple partners, and sometimes without regard for a person's usual sexual preferences. Sudden and spontaneous trips. Engaging in illegal activities such as shoplifting. Fast driving. Extreme agitation due to overstimulation. And they consider that to be like an overwhelming sense of simultaneous bombardment of all of their senses, such as hypersensitivity to light, sound, being in groups of people. Even small groups can be enough sometimes if more than one person is talking in the background. Aversions to certain textures, including foods, tastes, odors, physical sensations, physical pain. Some people have actually described awakening from pain from simply sleeping on wrinkled sheets or nightclothes that can cause bruising. More soft signs have been described as busy brain. That's my word. But they can describe the words as like watching them fly by like a ticker tape faster than they can speak, feeling that the words are buzzing or humming like a sewing machine inside their head, hearing a spoken phrase, short song lyric or musical tune, familiar or unknown, running in a continuous loop in their brain, including at night while they're trying to sleep. Migraines. So I fantasize about doing a research study on and this would be the title, Incidence of Chronic Migraines in Persons with Bipolar Disorder as a Psychological Signal to an Impending Manic Episode. So if anybody out there is interested in engaging in a research study, let me know and maybe we can collaborate. Out-of-body experiences. Most recently, I've had several people describe this to me, kind of on the hush-hush. They'll say that it's like a floating or a hovering over themselves as if they're observing themselves. But most of them will not typically disclose that symptom because they don't want to be seen as crazy. So the mixed mania that's been reported to me is most challenging, the longest time to obtain an accurate diagnosis. We all know that. But these are the ones that will describe things like I have a hard time sitting still with myself, which we know as akathisia. That can often be misdiagnosed as anxiety rather than mania. I hear clients talking to me about how they went to a doctor and they were given benzodiazepines or something along those lines to help deal with an anxiety when in fact it was the mania starting to creep in. These individuals also describe an inner sense of impending doom within their gut brain. And it's become abundantly clear to me in communicating with these individuals that they're willing to do just about anything to make it stop, including suicide. That mixed state is a scary, scary, scary space. And obviously it's the most difficult to diagnose. And when people get to this place, it's pretty rough. I've seen individuals who have gone from being diagnosed with either bipolar 1 or bipolar 2 when they were young, and their manic episodes were the fun, happy, joyful life of the party kind. But as they started to grow older, those episodes were changing and have become more of a mixed state. And I don't know if that's a typical trend, but I've watched that for quite some time now. And that would be another interesting research study, I think. So a word about suicide. In my opinion, I think we have a misconception about this. As professionals, I think we're not always asking the right questions. While we must do a suicide risk assessment, there's always one question that I want to ask. Do you really want to be dead, or you just want to make it stop? I follow up the first question with the second. If there was a way to alleviate your pain or those symptoms, would you be open to trying it? Another article, a brief review. I think this is a good indicator, pretty recent, about the mortality rate of individuals. So bipolar individuals with prevalent mental illnesses, we know it affects 1 to 5% of the total population. They have a chronic course that are associated with marked elevations, premature mortality. One of the contributors to life expectancy is suicide. So they say the rate of suicide is approximately 10 to 30 times higher than corresponding rates in the general population. That's pretty extreme, right? Exact research found that up to 20%, mostly untreated subjects, end their life by suicide. 20 to 60% of them attempt suicide at least once in their lifetime. And in this paper, they recapitulate the knowledge on those aspects and factors associated. Here's another blurb about that. And this falls right exactly in line with what I've been hearing for years and years. So it hasn't really changed. First, bipolar disorder is at least 20 times higher in prevalence compared to the general population. Additionally, there's a 20% lifetime risk of suicide in people with bipolar. It increases with age, especially if the person goes untreated for the disorder. So for me, when I read that, I'm thinking, okay, well, that makes sense to me as I'm seeing people who are becoming more mixed episodes. And I've heard over time in my studies and also when I was in school that it's those mixed states that we're most concerned about because they have that inner sense of impending doom. They have the angst and the energy to actually follow through. And so when I look at how it is that individuals are most difficultly diagnosed, or it takes the longest to get them to that place where we're seeing a mixed episode, we need to do better. So again, my opinion. Most often, bipolars express hopelessness regarding their present circumstances, particularly after numerous unsuccessful trials of psychiatric medications, years of misdiagnoses, and belief that there is no solution and no way out. We as professionals must aspire to do better. We must dig deeper and not give up on them, even when they have given up on themselves. I feel very strongly about that. And I would imagine that most of you probably do as well. So here are the areas that I think keep people from seeking help. So we've talked about the psychoeducation piece. Here's the grief and loss section. So there's a lots of sense of self.
Deborah,
yes.
Sorry, really quick question from the crowd before we transition.
Yes.
So Victor had a question about the episodes with age.
Mm-hmm.
And then, for example, can someone be type 1 and then change, or type 2 and then change to type 2? So like, is it a spectrum or is it kind of one or the other?
Well, it's my understanding that it's a spectrum, right? That's what the studies are telling us. But the trend shows me that individuals can go from the regular hypomania to more of the dysphoric mania, which is where I'm seeing the mixed episodes coming into play. So I'm not sure how well that answers the question. I think you could still consider that to be bipolar 1 or bipolar 2, but I think that the presentation looks different. And I think it also has to do with the length of time that an individual goes untreated before they're actually able to, progress forward. So I didn't put anything on here about it, but there are studies and brain mapping and all kinds of things to show what happens, as far as brain matter as that illness progresses untreated. That's a whole nother area.
Great. I think that answers it. And Victor just kind of commented that, we need to kind of reconceptualize what it means to be bipolar or bipolar disorder, which I think is a great point. So thank you.
You're welcome. Thank you, Victor. I appreciate that. So these are the things that they're telling me. And when you're looking at a professional that normally with the kind of help that we should be able to provide to them, the support, for them to be able to function at the highest level of their ability. These are the things they deal with. There's a loss of a sense of self once they've received a diagnosis, loss of their hopes, dreams, and futures as they knew it. Maybe that loss of what they would consider their special powers or abilities, which is that mania piece, that multitasking, the high energy and productivity, charisma, that sixth sense, the creativity, competency, self-worth. When a person gets a diagnosis with bipolar, all bets are off, because then they start questioning, well, what am I grieving? Is this who I really am? Have I always been this way? When did it start? What is this thing anyway? What is that going to mean for the rest of my life? How come somebody didn't notice it and help me sooner? So that brings us to a discussion about it. Let's talk about stigma. We'll talk about your experiences. So here's some of the questions. I'm going to put them out there and let's just chat about it. So what are your beliefs about an individual with bipolar disorder? Where have you gotten your idea about what someone who has this illness looks like? We have the media, right? We have family members. We have all kinds of things. I can tell you that I remember when I was first new to the field 35 plus years ago, and the up and coming thing at that time was borderline personality disorder. Everybody was getting that diagnosis. And I remember somebody telling me very clearly that if you're not sure whether or not a person has borderline personality disorder, well, if you feel the hair on the back of your neck start to stand up when they come in the room, then you'll know. I would tell you, for me, that I can know without even asking any questions. If I sit in a room with a person for 5 minutes, probably, I can see that they're bipolar simply because I'm drawn in. The conversation, especially if they are in a hypomanic phase, is captivating. I may find myself laughing and then wondering, okay, this is great, but let's stop. And recognizing that they just can't. And then I'm exhausted. So, characteristics of the first people that come to your mind when you have a client that's bipolar. Personality, professionally, personally, respected colleagues. What if you had one and you found out they were diagnosed bipolar? Would it change your relationship with them? What if it's you? What might you be concerned about as a professional who has bipolar disorder? So let's hear it. And I'll let you guys feel the questions.
So sorry, we have some comments coming in about how medications can also have kind of a secondary effect on people.
Yes.
Gain, which might affect their treatment, or labeling people as bipolar, just saying like, oh, that person's just bipolar.
Right.
And then, just kind of some of the cultural things that go along with that. So there's some good comments coming in relating to that.
Right. Anyone interested or willing in sharing an experience that you might have that maybe changed your perception one way or the other about what bipolar is or what you thought it was?
So Victor has shared, people looking at, their behavior just through that one lens, potentially.
Right. And seeing them as the diagnosis and not as a person.
Yeah. And then Christina commented, not necessarily changing their behavior of treatment of a colleague, but how it might help aid in their awareness or give a better understanding of their behaviors or symptoms. So again, not, treating that person differently, but just kind of creating a better understanding, which I think is a good way to think about it.
Absolutely. And on the flip side of that, when you think about the questions that I pose out there in offering the group that I'm going to be starting, is individuals who are afraid to express that they have it because they don't want their relationships at work or elsewhere to change. They're concerned about, even though we have the Americans with Disabilities Act and we have all these things in place that are supposed to protect individuals, it doesn't always go that way. Any further questions or comments from the community?
We had someone mention that, medications can be really beneficial, but also timing is really important. They said that they actually have a roommate that's missing their medication, and, just a short period of time being off that really threw things off. And then it made it more difficult for that person or that individual to get back into, kind of their groove, their normal routine, and when they were on their medication. And then Kathleen had a quick question about symptoms. Are hallucinations or delusions symptoms? Because she's seen a lot of people diagnosed with bipolar that have them, or are they misdiagnosed, as something else, or is it a comorbidity that occurs?
Yeah, so we know that in bipolar 1 disorder, that oftentimes, I think if not always, during a high mania in bipolar 1, individuals will experience psychosis. But they can also have that delusional system that we might look at with an individual and think that they're just being narcissistic, when in fact it is part of their delusional system. And so that's another thing to key into. If it appears that they're being obnoxious, maybe there's something more going on. That grandiosity.
Yeah, definitely. I think that makes a lot of sense. And then Alicia had a comment just kind of going with stigma and, how she had made a sarcastic remark about a moody person being bipolar, and then the individual she was talking to actually disclosed that they were. So it's important to always be very conscious of who you're talking to and be respectful, because you never really know if someone, might be dealing with that or not.
That's very true. Thank you for that. That's a good point. And again, with the way that, the media has kind of popularized it. We've had characters on television and in movies. And so we get our information about that. Oh, that's what bipolar looks like. Oh, and it is very common to have people throw the term around. Oh, they're just really bipolar today. Well, no, probably not. Let me see. One of the other things that can be challenging in working with or diagnosing an individual with bipolar disorder, or even helping them to understand that it's this range, right? And now with the way that it took years and years and years to create the DSM-5, one of the discussions was about, the spectrum, the bipolar spectrum, and what that was going to look like, and at what age can we actually start giving a diagnosis, and can it be in children? Is it going to be pediatric bipolar, or is it going to, bipolar NOS? And at what age is it really emerging? And so if in a system where there's a lot of dysfunction already, and you have an individual coming in, their life is in crisis and they need help, but they have a family member who's been diagnosed bipolar, the last thing they want to hear is, well, it kind of looks like it might be, a form of bipolar disorder, because they don't want to be associated with their experience, when in fact their symptoms might not be as severe, or they might present a little bit differently. So to help a client themselves to wrap their head around, you know, that diagnosis doesn't mean that you're going to be exactly the same as somebody else who has that diagnosis that you may have, you know, had a bad experience with.
So we had a few more comments come through, Deborah. So one is a little bit more about how bipolar presents. Oh man, let me find it. So is there like an age specifically where symptoms start to manifest?
So again, years ago in the DSM-4 and moving forward before we got to the DSM-5, we were just starting to see them recognize certain psychiatrists or people who were diagnosing would some on them say, oh yes, well, it's possible for them to start showing symptoms earlier. But the general rule of thumb was that you didn't start seeing those symptoms start to come until late teens, early 20s. But we're finding that's not necessarily the case. And if there's a family history, it's quite possible that you're going to see symptoms emerging sooner. You can see them. I've seen them in kids in their, 8, 9, 10 into teenagers. That's why you guys at Aurora, you see it all the time, right? Because you deal with adolescents.
Yeah.
Mm-hmm. If an individual, for example, and I didn't put this in there, but if an individual, like a kid, has a predisposition, a genetic predisposition to bipolar disorder or another mood disorder, and they start doing things like smoking marijuana, for example, when their brain is not fully developed yet, they could actually exacerbate those symptoms. And so we might see that sooner, where in fact, otherwise we may not have seen them emerge at all, or they may not have emerged till later on. That was something else I didn't put in here too that I should have mentioned, is that obviously there's different ways in which a person can end up with that disorder, right? So they could be having trauma at birth. There could be trauma from a traumatic brain injury that could create the symptomatology and the changes in the brain that were not initially physiologically that disorder per se. They could have had it as a genetic predisposition that went from generation to generation and had other family members that have it. I don't believe that it does just necessarily skip a generation. Sometimes we say that with certain things. We know that if there is two parents where one has a mood disorder and or a substance use issue, that their likelihood of having a child develop signs or symptoms of bipolar disorder is much higher. You can have a person that may have that genetic component in their family that never shows symptoms at all and seems to be just fine. Obviously, those people we don't probably ever hear about, right? Because they're not talking to us. But we may also have somebody that has a genetic predisposition that may have been doing fine and some sort of traumatic event occurred and the symptoms emerge. I think there's a huge genetic component to that. There's where, is it resilience? Is it totally genetics? We also have individuals that will present with the signs and symptoms that there's nobody in their family that has it. So we don't know of any genetic predisposition. They have no other connection to a traumatic brain injury, trauma, or anything else, and they present. So that is, I think, also part of the baffling thing when we're looking at this disorder in particular.
So kind of following up on that, we've had a few questions and then I've kind of thought of one of my own. So with the treatment and maybe prescribing for children versus adolescents diagnosed with bipolar, obviously if different things kind of trigger the disorder or exacerbate the order at different ages or different times, is there, a rule of thumb or kind of a best practice for that?
So obviously I'm not a prescriber. I've spent a lot of time, particularly when I worked in the community mental health centers, during the time when we had pharmaceutical reps come in and wine and dine us and do their talks about the medications and, you know, the studies and indicators for how they could use it, label, off label. I learned a lot about what medications were being used. And I also am intimately familiar with some people who have started that journey as children. And because I don't prescribe, I don't want to step my foot in and say, oh, they should do this or they should do that. But I think there again, it's important for prescribers to have their mind open to the possibility of seeing what's going to work with that individual. And I am actually going to get into medication a little bit more here in a minute. So maybe that'll help to answer it.
Perfect. Everyone's just excited. The comments are rolling in. But kind of quickly, just what comment that came in from Brooke, kind of mentioned the challenges of encouraging medication or encouraging compliance with treatment when people feel that they've, been successful or really thrived while they've been manic. So just kind of, again, trying to negotiate or have that conversation. Do you have any insights or thoughts on that?
I do. So let's hold off on that because I'm going to move through here a little bit more quickly now. And I'm actually going to address that very thing. So managing moods. Traditional schools of thought suggest that a combination of medication and talk therapy is the best course of treatment. Past research has shown this to have a high level of efficacy as well. But then there's the side effects. So another one of my opinions. I believe there's a solution, but not often accepted by prescribers, and no offense intended. For those who with moderate to severe symptomatology, psychiatric medications is likely the first line of defense to achieve relief. We are all aware of the incidences of medication noncompliance among persons with bipolar disorder. I've read so frequently and heard behavioral health professionals express frustration regarding their phenomena and hypotheses that these clients do not want to give up their mania. I would suggest a much higher incidence of medication compliance if these individuals were not medicated to the full therapeutic dose recommended. It's the feeling of being over-medicated, medically and physically incapacitated, mentally disorientated from the silence in their brains that justifies the noncompliance. I would suggest that on a much deeper level, these are the true side effects, which are intolerable, particularly for professionals. Thoughts about that? We also have to remember that for individuals who are open to actually considering medication, they may have been given several different things already and have come to the place where they don't want to be in a position where they're going to lose their job. They know that they're not at optimum capacity, but they can't afford to be in bed for 3 weeks while they're dealing with the side effects or the dosing. So I think that in that regard, we need to be more hypervigilant and sensitive to the needs of these individuals.
Lots of agreement with this, with this part coming through, Deborah.
Excellent.
Agreeing with you.
Yes. Thank you. Thank you so much. I'm happy to hear that because when I have this specific conversation with new clients about medication, I get so much more positivity about their willingness to consider it. And obviously, again, I don't prescribe, but I have seen people who, when given more flexibility and less over medicated per se, that they will be more compliant. I think it's a direct correlation.
So, sorry, just a few more things about this. Again, I know you're not a prescriber, but just kind of people had some questions about, your thoughts on, maybe people being on a very low dose or below a therapeutic dose. Have you seen success with that?
Yes.
Or do you ever encourage, are there certain patients, or is there a criteria where you encourage people to not be on any medication to manage their bipolar?
So I think it's a case-by-case basis. And that's why on the screen previously, even here, when they're presenting with moderate to severe symptomatology and it's getting in the way of their daily functioning, their life is unmanageable, they might be trying to self-medicate with other things like drugs or alcohol. Then I think that we want to take a look at the medication aspect. But here again, I'm very much a holistic, out-of-the-box thinker. So that talk therapy piece is extremely important. I can give you an example of a young client. I have a lot of young people, college age right now, actually, which I think is interesting. And one of my clients came to me in a severe episode, was very depressed, but rapid cycling. And I would say more likely was in a mixed episode rather than being just bipolar 1 or bipolar 2, right? So we discussed medication and they talked with me about their experiences and how they felt so over-medicated and all of these things that I've mentioned here. And so I watched them very closely. We had a safety plan. I was meeting with that client twice a week. And I gave them tools. I had them use a mood tracker on their phone. We had an agreement that if they got to a particular place where they weren't feeling safe, that they would implement that and we would get them to the hospital and they would then, talk about getting on medication, even just for a period of time, if that's what it took. And interestingly enough, these other things that I'm going to bring in as part of that holistic approach, as I move into a few more slides here, have been the kinds of things that have probably saved that client's life. But it's a commitment. So for some people, they would rather just take the meds than have to do all the other pieces to keep their life in balance.
Oh yeah, I think that's an excellent point. We've got a lot of comments coming in too, and I don't want to jump too far ahead. We have some people mentioning some different, therapeutic modalities, meditation, exercise.
Yes.
Asking about CBD products, if you found that that's been helpful at all. So again, I don't know if that's where you're going, but that's come up a few times.
So again, I don't prescribe and I don't say you should do this or that. I always give them the option,
sorry.
Right? No, but it's true that because those things are available and, if in a few weeks we have the deregulation of medical marijuana so that it becomes recreational, there might be a higher grade of CBD that has better qualities that can be utilized for individuals like this. For me, I think that the clients have to make that decision for themselves. Some of them have said that they've had positive experiences with it, but it's only part of that big puzzle, part of, all those other things that we're going to talk about. The problem, I think, is that it's not highly regulated. So you might pay, I don't know, clients have said they pay $75 to $100 for, a really concentrated level. And other people might be paying pretty close to that too. And the quality is just not there. So it's hard to say. Hit and miss.
That's a really good point about the regulation.
Mm-hmm.
Really quickly, we had a question come in a little bit off of the holistic approach, but maybe if you could highlight the difference between bipolar and borderline personality disorder beyond just suicidality.
Okay.
Question about that.
Right. So again, when I go back to thinking about and watching and waiting for years and years and years for the DSM-5 to come out and discussions about, trauma and spectrums and is borderline personality disorder actually just maybe on the spectrum of bipolar somewhere in there? Or is borderline personality disorder actually on the spectrum of anxieties right up there next to PTSD? I think that there's so many parts of symptomatology with many different diagnoses that we do need to be digging deeper. I have seen individuals that have been diagnosed with borderline personality disorder, which actually, to me, spending more time asking more questions appear to have that neurological component. Maybe I could put this out there. The best way probably to find out is medication, right? Because if you have somebody that's got borderline personality disorder and they're appearing to be kind of, quote, bipolar, right? You will know if it's borderline or bipolar according to whether or not a mood stabilizer of some sort, atypical antipsychotic, actually helps. Because I don't think that there's a lot of medications that are going to help with that piece, right? Does that make sense?
I haven't had any follow-up questions, but we're getting,
okay.
It's very interesting. We've had a few comments come through saying that as well, that that's a really interesting point. So I think that answered it.
Great. All right. So risk factors, running in families. I mentioned that. So 80 to 90%, these are newer numbers now. It used to be more like 60 to 70%. Environmental factors, right? Extreme stress, sleep deprivation, drugs and alcohol, vulnerable patients. Bipolar 2 often has those co-occurring comorbidities, anxiety, or substance abuse, or substance use disorders, I should say. There again, when I talked about that akathisia piece, I think it's important for us to look closely at, is it the agitation, the akathisia, that not being able to sit with themselves because they're actually getting into a manic episode? Or is it just anxiety? Because if you had an individual that does not want to hold the label of bipolar disorder, and I've had this happen, if they can go to a doctor and they're experiencing that level of intense stress and anxiety, and they're given a benzo or something else to treat that anxiety, sometimes it's just enough to bring them down so that they're willing to deal with that. And they don't want to look any further into any other possibilities. So that can be a detriment, I think. Again, my opinion. So more risk factors. I think that this individual is fascinating. And they talk about how it is a disruption to people's lives. When we think about things like the 12 steps, for example, and they talk about unmanageability, you see unmanageability in individuals who have bipolar when it starts to get to the point where they need intervention. So it interferes with relationships, particularly spouses and family members. It can cause difficulty in working or going to school. People with bipolar 1 often have other mental disorders such as ADHD, ADD, anxiety, substance use disorders, and that risk of suicide obviously is higher. So there again, thinking back on children, for example, this has been something that I think is fascinating. I've heard adult family members struggling with the behaviors of their children and looking at that as just being a badly behaved child, whereas in fact, they might be showing bipolar disorder or ADHD and not just behaving badly. Maybe they can't help it to some extent, right? So unless we can get more information to the parents and the grandparents, those caregivers, about what it actually looks like, because studies have shown that if you put a child that has ADHD and bipolar next to each other, those symptoms are almost identical. So for me, the way that I can tell a difference with a kid as I'm processing this is that if they have bipolar disorder, they're going to rage for hours. If they have ADHD, they'll get over it. That's what I cue into. But I've heard parents and grandparents talk about trying to discipline this child and to say, oh, well, you know, the parents just aren't being consistent, or, you know, why is my kid behaving badly? I just can't seem to get them to do what they need to do. The comorbidity between ADHD, ADD, and bipolar disorder in kids can be very challenging as well. So there's that medication piece. And then another way that I can tell with kids is that if they've been diagnosed with ADHD or ADD, and they've been given that, you look at the rule of threes, for example, if they've been given 3 different types of medications for ADD, ADHD, and they're still not really improving, it's probably the bipolar, in my opinion. Oh, sorry about that. On a positive note, this particular doctor says bipolar disorder is very treatable. Medication alone or a combination of talk therapy and medication are often used to manage it over time. Each person is different and each treatment is individualized. Different people respond to treatment in different ways, and people with bipolar disorder may need to try different medications and therapy before finding what works for them. I was so happy to see this in an actual article. So, best kinds of treatment. On the left, I have this psychiatric medication combined with the talk therapy. There's the neurological interventions, right? So we hear about ECT. Now the transcranial magnetic stimulation we're not getting paid by, as you guys know, over there at Aurora for doing that through the insurance companies yet for a person who's been diagnosed bipolar. But that's probably, I hope, on the horizon. EMDR is another way that sometimes people, because I believe there's almost always a trauma component that's involved, whether it's the trigger or whether it occurs as a result of a person just simply having this disorder, the traumatic experience. So I look at everything through a trauma-informed lens. So that holistic balanced living, here they are. If you look on the right, the healthy eating, moderate exercise, daily routine, keeping that circadian rhythm, very vital. Refraining from drugs, alcohol, nicotine, and caffeine, minimizing stress, yoga, tai chi, meditation, spirituality, breath work, purposeful activity. For me, that's huge. Any of you who know me will have heard me say a million times, intrinsic value, intrinsic value, intrinsic value, helping them to find a sense of meaning in their life. Naturopathic medicines and supplements. We don't know nearly as much about that as I think we could. I personally am extremely interested in that. And if any of you out there are naturopaths that specialize in bipolar disorder and have had success in working with individuals through supplementation and other kinds of natural methods, please let me know. Reiki, acupuncture, acupressure, music, movement, different forms of art and creative writing, creative expression. Huge. So that's what I'm talking about when I'm talking about that bigger picture. I love when I have a client that's doing well on medication or off. I always recommend that they have the big picture. I love when we can have a conversation that's not deeply intense about trauma. If I have a client that comes in and they're talking to me about some picture that they're painting that reminded them of a scene out of a book that they read recently, or they went to a naturopath and they got a supplement that's really helping them to sleep, and they're on a schedule, they're going to the gym, they're eating healthy, it's a good day. It's a really good day.
So Deborah, sorry, really quickly, just want to interject here. We had a question come in going back to, you mentioned children with ADHD versus bipolar. So I know this is a slight step back, but
yes,
They're just wondering if you found the same thing with adults, if they're not having success with ADD medication, could that indicate bipolar as well? Or is that more of a phenomenon with children? And just really quickly as well, we have about 25 minutes left, just to give everyone a time check.
Thank you. I hadn't really thought about it until as I was working on this, and I would have to say, yeah, why not, right? We're getting a lot more people now that are being diagnosed with ADD and ADHD as adults. Another piece, since we're talking about medication too, we want to be familiar enough, even for those of us who do not prescribe, that for an individual who has bipolar disorder that goes to a primary care doctor that may not be well versed in psychiatric medications and they think that they're depressed, there's the rule of threes again. If they're getting all these antidepressant medications and they're feeling worse, studies are showing that an individual who has bipolar disorder that takes just an antidepressant can actually throw them into a mania unless that antidepressant is taken in conjunction with a mood stabilizer or some kind of atypical antipsychotic. I didn't put that in there either, but wanted to put that out there.
Great.
Okay. So again, those risk factors, right? Change is significant and clear to friends and family. Symptoms are severe enough to cause dysfunction and problems at work, family, or social activities and responsibilities. Symptoms of a manic episode may require a person to get hospitalization and care to stay safe. So here you have it. They're still saying the average age for a first manic episode is 18, but it can start anytime in early child to later adulthood.
So Deborah, quick, we had a question, obviously this would be for anyone who had, a manic episode earlier in life. Have you experienced or with any of your patients long-term seen any side effects of for children who have been on medication for a long period of time?
So because I don't specifically work with children, but I have close contact with individuals who started as children and I knew them as children and I've seen how that's happened. I think one of the greatest challenges with children is that when they become 18, they become oftentimes very medication non-compliant. And I think that's the biggest side effect because we just don't know enough about what's really happening. So with all the mixed messages, even with kids who are bipolar, that they might be able to hold it together at school, but the second they get home, all hell breaks loose. And there's the shame and the stigma of parents not wanting the outside world to know what's really going on at home. And so that might keep them from getting further intervention with the kids that could be helpful.
I think that's an excellent point and something I hadn't thought about, that non-compliance as being a side effect in itself. We also quickly kind of thinking again as the holistic side that you just covered, Brooke mentioned the importance of sleep.
Yes.
Because if a client isn't sleeping, maybe they're manic, that can manifest in a lot of ways and negatively impact them.
Right. Absolutely. It just filters all the way down. So that, again, I love technology for clients to be able to have the ability to do the mood trackers on their phone or to do it in writing on a graph if they prefer, or to have some sort of a way of keeping track of what's happening in their life, what's happening with other symptoms. There may be things that are coming up unconsciously that they're not even aware of that are affecting their moods, right? So we need to, that's another piece of the importance of them having a therapist that they can be in communication with on a consistent basis. Even if sometimes they're only seeing them every couple of weeks or once a month because they're doing well, to have somebody who knows them. And also I encourage individuals when they first come to see me, those mood trackers, so that then if they are going to go to talk with a psychiatrist or a psych NP prescriber of some sort, they'll have a bit of a pattern, hopefully, that they'll be able to show, look at, this is what's been going on. So here, this is for your information as well. Okay, navigating relationships. This is tricky. This too, I would say, is a side effect of noncompliance. But these are the reasons why oftentimes people come see me. Intimate partner relationships. There may be infidelities, mismatched sex drives. Oftentimes when individuals are manic, they tend to have a heightened libido. Multiple breakups or divorces. Basic trust issues about sex, money, you name it. Family, friends, colleagues, bosses, they're under constant scrutiny. There's a lack of respect, questioning one's integrity. So what is the client thinking? They might be thinking, at what point in a relationship, particularly a new relationship, do I reveal my diagnosis? Imagine going on a date, finally getting up the nerve to become social and struggling with trying to figure out what that might mean for their future with somebody and being able to experience love. What if they leave me when they find out? What if I'll never find someone who will love, understand, accept, or stay with me? What if people can actually tell that I'm having a bipolar moment, or that that's actually what's going on with me, and then it's not my personality necessarily? What if I can't tell that my symptoms are rearing their head? What if my children hate me? More things clients might be thinking. Am I allowed to have a bad day without somebody talking to me or taking me to the hospital? What if I have 2 bad days? Can I truly trust myself to manage my moods? Will others allow me to manage my moods? Am I going to get fired? What do my coworkers really think of me? How could I do and say such horrible things? Why can't I remember what I said or what they said I did? That's something else that I haven't put in there, and I haven't read a lot about it, but through clients describing this to me, I would refer to it as bipolar blackout. Oftentimes when a person is in a manic phase or they're in the process of becoming manic and they get bombarded, it's really no different than an individual who is overstimulated with those trauma activations. They can't think straight. They go into a blackout and they do and say things that they don't even know. And they'll have people coming to them saying, how could you have behaved that way? Why would you say those things about me? This is so unlike you. And the client has no recollection in the moment, but sometimes after the fact, it'll hit them. And it's very, very, very difficult for them. They feel like everybody's blaming them for hurting them, destroying their marriage, spending all the money, crashing cars, losing the house, the job, the friendships, causing the kids to do X, Y, Z. And they realize they didn't mean to do it, but they couldn't help it. Sometimes clients will say they actually will go and isolate themselves, knowing they feel this inner drive to say or do things that is not characteristic of who moralistically they are, but they can't help it. And they're trying to minimize the collateral damage. There's a lot of shame in there. And questioning, why don't they see that I did or I am doing the best I can? And then there's that recollection, right? Oh no. I remember what I said and did. It was shameful, embarrassing, mean, hurtful, funny. Thoughts about that?
Brooke actually just submitted a comment saying that some of her clients get frustrated, when they're wanting to disclose their diagnosis, then they're trying to hide it, and then they might not remember what actually happened. Do you have advice? And then she followed that up with, asking if you have any advice for accountability or advice you can give clients about accountability to what happened after something like that.
I think a lot of that goes to creating safety for the clients themselves and helping them to have a really good understanding of what the illness is first, and that it's a part of who they are, but it is not who they are. And that's where that forgiveness piece comes in. To be able to create that space for the client to be accepting of themselves, that I did the best I could. And even there's going to be times when they're not going to be able to explain away what happened. And there's going to be people in their lives that are going to leave. They're going to be angry. They may hold on to resentments towards the clients for years and years. I've seen many, many relationships fail as a result of this lack of acceptance and understanding.
So kind of building off of that, someone asked, how much, kind of what the balance is between personal accountability and, quote unquote, blaming your bipolar disorder for your actions.
Right. So that's a great point, right? Obviously, I think it's no different than an individual who maybe committed a crime, right? They may have been mentally incapacitated at the time, but they still did what they did. And there is a sense of accountability. They need to take ownership of that, but also with love, right? Yes, I'm sorry. I didn't remember that. I didn't realize that. But then maybe to start a dialogue with, can you help me to understand what happened? If you see things starting to go this way again, could you please maybe give me a signal so that I can try to stop it from happening by going and taking care of myself? But yeah, they do need to be accountable, but they also need to be moving forward. To be stuck in a place where they've done something that they can't change. I tell all of my clients, today's a new day, right? Yes, yesterday informs on what happened then, and it helps us to see where we are now. But the choices and the decisions that we make today are what are going to propel us forward. And just the other day, I coined a new one of my phrases, and it was, whatever the difficulty is, even if it's uncomfortable, taking accountability and choosing anyway. Sometimes it can get ugly.
So again, kind of on that same note, do you suggest, working with family members who've been involved in these repeated episodes and start to harbor resentment? Or when do you recommend, when those dynamics start to change? What kind of involvement do you usually suggest for family members?
I do like to bring family members in small amounts at times, depending on the situation. So if it's a couple particularly, a lot of times this will happen. I'll start working with the client and they'll talk to me about recognitions that they're having. And then I'll start doing some couples work. And sometimes I'll actually, after the first session with them together, I'll meet with, the significant other individually just to see what their level of trauma is and their collateral damage in dealing with this, because they're not getting a lot of help and support either, because they've got shame and stigma about going and talking to other people. I had a client just recently that got into a fight in public, a verbal altercation with her significant other, and it was very public. Other people saw and heard them, and the spouse is mortified. And so I'm working with that individual on the side and with both of them. But the other part of that is I see psychoeducation being extremely important. Hey, this is what I'm seeing. You know, what's been your experience? What are you willing to do? How can I support you in that together as a family or as a couple? And not all family members are up for it. They might be at a place where they're just like, I'm out, I'm done. I don't want to deal with this anymore. I'm burned out.
So I have a few more questions coming in. So the first is about, have you experienced, a family member of a patient with bipolar coming kind of codependent, feeding off that behavior with each other? And then kind of the second question to that is distinguishing between a bipolar symptom versus just a general struggle with mood or interpersonal relationships, especially if someone doesn't, present with quote unquote classical manic symptoms or manic episodes.
Good questions. So the first part of your question was, say that again.
So it's from two different people, but they went really well together. So
right.
So the first one is asking about, relationships between someone with bipolar and their family becoming codependent.
Oh, yes. Okay.
Answer that first.
Right. Well, in a lot of ways, it's not terribly too far off from a person who might be dealing with a substance use disorder, because that unmanageability piece is very similar. And so there are family members who, like I talked about, that shame piece, right? They're going to be rushing around, especially in public, the scenario I just gave you, trying to make sure to contain that individual, keep them away from other persons that might bring a bad light to their relationship, their family. They're not going to want to get, people thinking that DCS needs to be involved or any of those things. So there's going to be a level of codependency because they're going to be running around trying to contain. But at the same time, if they're not burned out and the client starts to get better, the family member is going to have a difficult time sometimes letting go of all the things they were doing in that codependent piece, right? Because now their job is over. So it's about teaching them how to adjust, learning a new dance, and dancing together in a way that's healthy for both of them. And therein, just like substance use disorders, mental illness, it's a family illness. Even if it's just one person who's got the diagnosis, it affects the whole system, and they all need help.
So Deborah, I know that I had a second question built into that, but I just want to give you a heads up that we have about 7 minutes left.
Okay.
So if you want to finish going through your slides,
yes,
you can ask the rest of the questions afterwards.
Perfect. Okay. So the relationships piece, right? So these are the kinds of things that maybe other people are going to be thinking when they're seeing an individual that's behaving badly. I wonder if they took their meds today. They look a little too happy. I bet they're going manic. What if they have an episode at work or out in public? What if they embarrass me? What if they spend all my money or our money? Who is this person really? I don't even know who the real person is. They're such a narcissist, selfish, fill in the blank. So, a new normal. How can we best help professionals embrace who they are without losing themselves? And we've been talking about that all the way along. All of these things are relevant. Here's what the clients are telling me. Professional bipolar clients want to be treated as active and respected collaborators in all aspects of their mental health treatment, and particularly in terms of medication management and alternative therapy options. We need to bring their humanism to them and to let them know that just because what they're dealing with is considered an illness and other people can't see it, in so many ways, we want to remind them that it does exist. What they're experiencing is real. help is available, and we're going to be with them every step of the way. There you have it.
So really quickly, I'll jump back into the few questions that came in before. Thank you. Again, lots of really good questions, lots of really good info coming through. But kind of going back to that other question about differentiating between, bipolar symptoms versus general struggles with mood or interpersonal relationships. Is there a certain point where one struggle, is a definitive symptom? Especially in relation to someone who might not have a more typical, quote unquote, manic episode, if that makes sense. And I can.
Sure. So I think that is where we as professionals really need to do our homework. We all can benefit from a trauma-informed perspective. The more background we have in trauma-informed approaches, the better off we're going to be able to interact with all of these people, because then we're looking at them from, here's who you are, I'm meeting you where you're at, let's talk about what's going on, and not be jumping to the medical model of slapping a diagnosis on a person, throwing medication at them and putting them on their way. I used to be one of those people that was all excited about, oh yes, there it was in the DSM, right? I see it, this is what it is. But I've changed that radically now. And I think relationship is huge. I think it's really important to get a bigger picture of what's going on with each of these individuals before we jump to that conclusion. So to provide possibly with, a working diagnosis, but a rule out maybe, or 2 or 3. Because we truly can't tell 100% in the very beginning with what an actual diagnosis is in a lot of situations. We have to do it for insurance. We have to do it for crisis situations. We have to do it for hospitalizations. But it's the relationship piece that gives us the information we need. And we as professionals need to be able to distinguish those differences. And I think experience helps too, in working with different people from different walks of life over the span of time, to be able to go, oh yeah, that's right, I remember that client was presenting like this, and I thought maybe this is what was going on, but actually now that I'm allowing myself to be more open-minded, it's probably this.
So kind of building off of that, so someone shared that they've been having concerns with their older mother, who actually has suffered from depression, but now is maybe showing more signs of borderline personality or bipolar depression. And just kind of wondering, is that typical? Is that maybe just a side effect of dementia? Do you have any insights on that?
So if an individual has not had a medical evaluation to rule out neurological things, I always encourage individuals, hey, when was the last time that you saw a doctor? Why don't you go check in with your PCP and see if there might be something physiological that's not a mental illness that's happening in your body. Sometimes we can see symptoms of bipolar from things that are side effects of other medications. I've had clients, several recently, talking about issues with thyroid. They can present as bipolar. I've had individuals, several females recently, talking about birth control and how that's causing all kinds of mood swings. And now I'm seeing more PMDD. And is that bipolar or is that PMDD? Is it something they're dealing with in addition to that? There's just so many variables. We need to just always be on our game. But rule outs are important. Go to your doctor. Make sure to get your blood work. If there is more going on, let's get that MRI, especially if it's a person that's older, that's had depression, because we don't know what's happening in the brain. We just don't. And I can't see it.
Wonderful. Well, folks, I think we are about at time here today. So really quick here. It looks like you put up your contact information there.